Good afternoon, everyone. Welcome to the next session of the 2024 Fetal Cardiology Virtual CME Series. We're going to give it a few minutes to let people join. We'll give it one more minute and then we'll begin. All right, I think we're set to begin. Welcome everybody again to the next session of the 2024 Fetal Cardiology Virtual CME Series. Today we're joined by Dr. Ali Shaibani, who comes to us from Northwestern Medicine, where he's the section head of neurointerventional radiology. He brings extensive experience in the areas of cerebrovascular disease and stroke, and he has led 2 comprehensive stroke centers and established multiple service lines in disease-specific clinics. Dr. Shaibani completed his medical degree at Northeastern Ohio University College of Medicine. He did residency at the University of Pittsburgh Medical Center and radiology fellowships at Washington University School of Medicine and the University of Miami Medical School. Today, Dr. Shaibani will be talking about vein of Galen malformations. And Dr. Shaibani, if you could advance to the next slide.
Sure. These are, I think, our standard slides.
So thank you, to the Echo Lab for supporting this lecture series. Today's lecture will be available not on the NM Cloud webpage, but rather on a private Lurie Children's YouTube webpage, which will be shared as of tomorrow. And just a reminder, this particular session will not be available for CME credit, unfortunately, just due to limitations in being able to provide this series overall to a greater audience. Right.
Okay, great. Thank you very much for the introduction. I appreciate it, and thanks for the invitation. So we're going to talk about vein of Galen malformations. This is one of the congenital intracranial arteriovenous shunts that, while rare, is the most common one to sort of present with neonatal, especially cardiopulmonary failure. Although there are several presentations that we're going to go through. These are congenital midline arteriovenous shunts, which involve the choroidal fissure. So you have the malformation extending from the foramina of Monroe to the atrium of the lateral ventricles. And it consists of like 30% of pediatric intracranial vascular malformations. And they likely form between weeks 8 and 11 of gestation. So the arterial supply is from all the choroidal arteries and what's called the limbic arcade, which is the arcade around the corpus callosum. And then you have subependymal arteries from the basilar artery and the proximal segments of the posterior cerebral arteries. Now, these are all branches that shunt into a major recipient vein, which is it's a misnomer to call it vein of Galen, but in the initial description, they thought it was the vein of Galen, but it's actually what's called the median prosencephalic vein of Markowski, which is a vein that normally regresses, but partially forms the vein of Galen, but in this case, it doesn't regress. The outcome natural history, especially of the neonatal and infantile versions, is poor. Certainly without treatment, it's uniformly pretty much terrible. So there have been two classifications primarily utilized. The Yashargil classification was an initial classification by a famous vascular neurosurgeon, Ghazi Yashargil, and he went through type 1 through 4. The more simplified classification is probably the more relevant one that Pierre Lastenius in Bicêtre, France did, which is what's called the choroidal vein of Galen malformation. And these are where you actually have a nidus of arterial branches that then shunt into this recipient venous pouch. And then there's a mural, which is a fewer number of arteries directly connecting to the vein. We're going to have a picture coming up shortly that you'll see this. So this is a cartoon from a nice article that came out maybe 7-8 years ago. This actually is showing you the modified Yashargil classification, but the mural is really that type 1, where you have a dilated vein with, several arteries that directly fistulize into it. And this also shows what's called a persistent Falcine sinus or a straight sinus. They rarely coexist. Whereas the choroidal version sort of looks like this one here or that one there, where you have this fine network that then communicates with the vein. There are 3 types of presentation. Neonatal is considered to be the most common, although it's fairly close, I think, in percentages with the infantile presentation. And the neonatal is the one that especially, has a big cardiac component to it. So these are kids who present with cardiopulmonary high output failure and pulmonary hypertension because there's such a large intracranial left to right shunt, and they have a high risk for brain injury because of the intracranial venous hypertension, and they usually present within hours or days post-delivery. Rarely they present after 30 days with a similar sort of presentation, and they can, besides the brain problems, you can get secondary multi-organ dysfunction. You get hepatic, usually dysfunction due to congestion from the right heart failure and elevated back pressure into the hepatic veins. You can get renal and intestinal failure and ischemia, basically, due to poor antegrade aortic flow with reverse flow and diastole. The infantile, technically speaking, is after age 1 month, but most often you see it between 3 and 12 months. The degree of shunting in these cases is not high enough to cause cardiac high output failure, but there is significant intracranial venous hypertension. So these kids usually have delayed neurologic milestones. They usually have very large head circumferences, and they have dilated veins over the face and forehead as collateral veins. And it's due to what's called a hydrodynamic hydrocephalus, because cerebrospinal fluid actually drains through the veins. And if the pressure in the veins is elevated, so it builds up. And you can have brain injury, especially white matter injury. And in severe untreated cases, you get something called a melting brain syndrome, where the brain tissue just starts melting away. So this is a nice recent paper, relatively recent paper about fetal and neonatal MRI predictors of aggressive early clinical course and vein of Galen malformation. And this is out of the group at Boston Children's, who's done a lot of good work in this. And they looked at their cohort of, I think originally it was 49 patients, but they found 32 that had this sort of cardiopulmonary failure presentation, the neonatal technically presentation. And they tried to look back at the imaging to figure out sort of, can you predict who's going into heart failure? And what they found was that if they measured the diameter of the draining vein, in this case, either the straight sinus or the persistent falcine sinus, that the diameter really predicted presentation with cardiopulmonary failure. And you can see that in this table, the probability of cardiopulmonary or neonatal aggressive presentation is how they've termed it, sort of really correlates with the diameter of the vein. So once you get to 8 millimeters, for example, or greater, it's upwards of 88%. Now, as we mentioned, the hydrocephalus and vein of Galen malformations is not due to obstruction of the cerebral aqueduct. In most cases, that used to be the traditional teaching, but it's really secondary to venous hypertension and consequent malabsorption of CSF. And that's because actually arachnoid granulations and villi are underdeveloped at birth, and they sort of fully come into their own around 18 months. And the venous system is still undergoing development. For example, at this age at birth, the cavernous sinuses are not really functioning and fully developed, and neither are the jugular bulbs to some extent. So in the situation where we have hydrocephalus, for example, in the infantile type, a reduction of 30 to 40% in the arteriovenous shunt will usually cause arrest or reversal of the hydrocephalus. And so we tend not to do ventricular peritoneal shunting as the treatment, because that actually can make it worse. So only if after embolization, if there's a hemorrhage or some other cause of hydrocephalus, then they get a ventricular peritoneal shunt. We're going to go through a couple of reviews of sort of outcomes. As we mentioned earlier, the outcomes without treatment are uniformly horrible. This is a meta-analysis published in 2017, where they looked at 578 patients. About 42% were neonates, 45% were infants. And they found that neonates were significantly less likely to have good neurologic outcomes with treatment at about 50%, whereas 77% of the infantile had good outcomes. And these are short-term outcomes. And of course, congestive heart failure at presentation had a correlation with bad outcome. This is a scale that was developed by Pierre Lasjanius and the multidisciplinary team in Bicêtre, France. And they probably had the single largest series of patients with vein of Galen malformations, because they received all the patients from France, but also from many francophone countries and surrounding countries. So they had, I think, over 250 patients, and they came up with this scoring system, which is still quite relevant. And if you look, it looks at cardiac function, cerebral function, respiratory, hepatic, and renal function. And, this is one of the scales where a low number is bad. And so if the child or neonate or infant scores less than 8, that even with treatment just has no good outcome. So they don't recommend treatment based on the scale. And the scale has held up generally. 8 to 12 would require emergent treatment. Greater than 12, they had recommended, ICU medical management, seeing if we can get the child to sort of develop until they're about 4 or 5 months, where the treatment's easier. Now, I agree with some more recent articles where it says it's, in our experience, it's actually hard to get these greater than 12 medically managed without seeing some brain damage occur. So, we are probably more likely to intervene even in this group if, there are some other concerns, especially on brain imaging. The presentation by age group is interesting. So if you look at the neonatal presentation, congestive heart failure is much higher, followed by the infantile, and lastly by the childhood presentation, whereas increasing head circumference is more common with the infantile presentation. These are basically the outcomes that we talked about with treatment. And the percentage complete occlusion, you don't have to completely occlude this lesion to actually get them out of the cardiopulmonary failure or to arrest their hydrocephalus. Now, eventually, you want to cure the lesion because of the risk of future bleeding. This is a very nice paper, relatively recent, from the United Kingdom. They actually have a system where there's only 2 hospitals in the UK that receive all kids with vena Galen malformations. So they have the ability to sort of really look at the outcomes, as opposed to the US, where, like, for example, in Chicago, there is not all kids are transferred to Lurie, for example. They may end up being either not treated or treated at one of the outside institutions. So they found that if you look at the neonatal presentation, and this is more recent than the Bisset-French experience, they still had more than 1/3 that didn't survive. And out of the survivors, about half had a good outcome, and half still, while alive, had what would be considered a poor neurologic outcome. Now, there's some work on the genetics of vena Galen malformations, but it's not really quite where we, can use it for any particular purpose. And this is one of the algorithms for treatment in one of the articles we talked about. I'm going to show you some cases. So this is a 7-day-old boy. He did not have a prenatal diagnosis. At day 7, he had heart failure, tricuspid regurgitation, respiratory failure, pulmonary hypertension, and intestinal ischemia. And this is his MRI. So you see the very dilated vein with a persistent falcian sinus and prominent transverse sinuses. So there's some early hydrocephalus. But the best thing is that the brain itself looks quite good. And that's what we want to see. So this is a first session of embolization where we've gone through the vertebral artery into the basilar artery into the posterior cerebral artery. And in this session, 2 large pedicles arising from each of the posterior cerebral arteries were embolized. This is the cast of the embolic material. And one difference between what we do, at least compared to the Europeans, is that they tend to use a lot of NBCA, which is an acrylate glue. And I think a lot of us tend to use onyx, which is a little more controllable. So outcome after the first embolization is within 3 days, the heart failure intestinal ischemia resolved. The patient was discharged home, neurologically intact on follow-up. And then we could wait until about 8 months of age for the next embolization. Now, this would normally be a video that shows you 4-dimensional flow that we can measure actually through each one of these arteries with MRI, but I had some technical issues earlier. I'm showing this on an iPad, and unfortunately, I can't show you that. So this is second session embolization. Just a few more pedicles closed. And this is the mural type, the one with a fewer number of arteries connecting to the vein. So this is a 2-month follow-up after the embolization. You can see the hydrocephalus is resolved. The vein is smaller. The brain looks good. This is an 18-month follow-up. Brain looks very good. There's no hydrocephalus. The vein is even smaller. And so this child had a very good outcome, thank goodness. This is a 3-day-old. She had a prenatal diagnosis of vena Galen malformation. And then, she was from out of state, but she came to deliver here with us at Prentice. And she presented with heart failure, pulmonary hypertension, reverse diastolic flow, and a Bisset score, a little, probably 13. And this is the day 1 ultrasound. So you can see a very massively dilated median prosencephalic vein and extending into the persistent falcine sinus on the color Doppler. We see, the massive flow through this. She also had partial anomalous pulmonary venous return, ASD, sinus venosus defect. And she eventually had repair of partial anomalous pulmonary venous connection. So this is the initial MRI, MRA. You can see this vein is much more dilated than the first case that we saw. This is what's called the diffusion weighted image, looking for areas of ischemia in the brain. Fortunately, none were present. And you can see the massively dilated vein here. So this was a first transarterial embolization on day 3 of life. And I closed 4 large pedicles. And this is an older case. And I thought, well, this is probably going to get this kid out of heart failure. But it really didn't change the condition. You can see how much stuff we've put in there to close these branches. So we ended up doing a total of 4 embolizations in the first 16 days before she actually got out of cardiopulmonary failure. So you can see the cast of the material after the second and third embolizations. Now, fortunately, she did, thank goodness, quite well at 16 months, neurologic cardiac exam normal. This is a 1.5-year follow-up. Brain looks good. The ventricle's a little dilated, but I think that's just, if they start dilated, even if you fix it, they don't always get back to normal looking, but even though there's no sort of venous hypertension. And that's a 2.5-year-old follow-up angiogram with complete occlusion of the malformation. This is a third case, 6-day-old presenting with high outflow cardiac failure, pulmonary hypertension, and decreased visceral organ perfusion. So this is the contradistinction to the one that I just showed you, which we will see shortly. So you have the familiar appearance of the dilated median prosencephalic vein. In this case, it's sort of protruding into the ventricle. The brain looks overall pretty okay. There's some white matter changes here. So this is embolization age 6 days. Here's closing a lot of the supply from the right, and then went and closed some of the supply from the left. I would say this was about an 80% reduction of flow, which just after the previous experience where we had to embolize 4 times in 16 days, we thought maybe this was a good thing to close this much at once. But she actually had such a collapse of the vein that she ended up with an intraventricular hemorrhage and had hydrocephalus. Eventually, neurosurgery placed an external ventricular drain, but you can see, some of those white matter areas of injury are seen much better now, and certainly there was some injury because of this hemorrhage and hydrocephalus. 6-month follow-up angiogram shows an occlusion, continued occlusion to the vein of Galen, and this is what we would consider sort of a clinically silent, but certainly complication of the original embolization where the common femoral artery on the right is occluded. But this is the brain follow-up study, which looks pretty okay. But this is an example of a patient who already had some white matter injury. And white matter injury causes more global dysfunction than cortical injury. So in the 15-month physical therapy, occupational therapy, we can see that there's definitely some cognitive issues. So she's low average, fortunately still in the average scale. Motor at that point was extremely low. Now she's older. So the questions that, come from these types of cases is, we know each embolization, session carries risks up to 18% per session in some neonates described. We've been fortunate, 18% is a little high compared to the series we've had. We've treated, I would say, 25 patients. And so one of the questions we had sort of asked ourselves was, how do we predict how much to close in a session? And then we've done some work with the 4-dimensional flow and trying to quantify flow, but it turns out one fairly low-tech version of it is to actually insonate the descending aorta while you're embolizing. And when you see the reversal of diastolic flow resolve, that's a good time to stop, because I think that sort of, according to people who've been doing that for some time, that's a good sign that, you've sort of shut down enough flow for them to get out of heart failure. So what are the new developments? This is a publication from, I think, last year, actually. So this is out of the Boston Children's Group. So it describes the first case of an in utero intervention. And so as we talked earlier, the neonatal ones are the ones that do the worst. And with prenatal diagnosis and measurement of that transverse diameter, you can sort of predict who's going to do badly. And about half the survivors with postnatal treatment still have some cognitive issues and neurologic morbidity. So the theory or the hypothesis for them was maybe it's feasible to treat them in utero and prevent some of those morbidities. And so they treated this patient. The fetus was 34 weeks and 2 days. Sorry, the diameter of the Falcine sinus was such that there was a 99% likelihood of neonatal decompensation. And so they actually had developed a protocol. And this is a multidisciplinary team, obviously, with maternal fetal medicine, neurointervention, cardiology, peds cardiology. And they basically access through the skull with a needle through the uterus, and then place some coils in that recipient venous channel. Now, what they saw was that there was a 43% reduction in total cardiac output after they did this, and that varix, that enlarged vein, certainly decreased. There was no, subarachnoid hemorrhage in the head, but there was a premature rupture of membranes, and so the child actually was delivered, I think, 3 days later. A group in France actually did a case too, and this is a publication with one year follow-up. And this one was a 34-year-old lady who was pregnant at 31 weeks. They had a prenatal diagnosis of the malformation. Fetal MRI at 32 weeks confirmed macrocranius and cerebral ventricular megaly, but there was no evidence for white matter injury. And then they saw that the diameter portended an 88% risk of worsening or significant heart failure after birth. And so, after discussion with the parents, where they said, there's only a 30% chance of survival with a normal cognitive outcome if the baby's born and treated postnatally, the parents consented to this treatment. And you can see this is a cartoon of it. They actually performed the procedure at 33 weeks with epidural analgesia, tocolysis, fetal anesthesia. They actually had to manipulate the baby to bring the head into a position that they could use the ultrasound guidance for. And they introduced an 18-gauge needle. And there's a video of this. If you go actually on PubMed, you can actually see it as a video. But there's an 18-gauge needle through which they put a standard catheter, like a cerebral aneurysm catheter, and then introduce the coils. So this was, I would say, both of these cases are proof of principle, and showing that you can do this with relative safety. This child was delivered at 38 weeks, but still had to have relatively, I would say, early intervention because of cardiopulmonary failure. So day 5 after birth, they did standard treatment. And their thought is they didn't put enough coils in the vein, and that may have been the reason. So I think the theory here, the hypothesis is, can we prevent the brain injury by doing a fetal intervention? And I think what these two cases show is that it's certainly feasible to do it, but we don't know enough about whether it's making a difference. And so this study is hoping to recruit 20 patients. One of the things to consider is what happens to the circulation within the first 24, 48 hours after birth. And I think this audience is quite aware of it. And this is a nice article out of Canada, Calgary, that shows some of the transitions that happen in various organs in the first 24 hours. And I think one of the more interesting things to think about is that you go from an in parallel circuit in utero to an in series circulation. And the placenta is a low resistance circulation, which is somewhat cardioprotective, and that goes away. And so the real question I think that comes to me is, it is very interesting and cool that we can do this in utero if needed. But another possibility, an alternative possibility, is if we prenatally identify the kids who are probably going to do poorly, it's also feasible to do a planned delivery and then intervene ex utero in that first 24 hours before this full transition, which is what actually causes all the problems, the transition fully to sort of the ex utero circulation. And that can be done either transarterial via the umbilical artery, which is what we do actually a lot of the time, but the transvenous approach is also feasible once the baby's born. So I'm going to stop here and see if there are any questions.
Thank you, Dr. Shaibani. That was very, very interesting. Let's see if there's any questions. If some of the attendees have any questions, please feel free to put that into the chat. While we're waiting for any questions, Dr. Shaibani, so I saw from your presentation that postnatal treatment often takes multiple interventions, and it sounds like you really have to be careful about how much you do. So what do you use to determine when you kind of stop each embolization? Do you use
Yeah, that's an excellent question. So, their limitations are one of its contrast, because we tend to sort of use a maximum of 10 cc's per kilo of contrast. And so that's where the cross-sectional imaging is really important, because if we can establish the arterial anatomy well with the MRA before, then we don't have to do as much diagnostic injection. And we can sort of say, okay, you know what, I'm going to go up the right posterior cerebral artery and pick that pedicle. And so we minimize the contrast. But contrast itself can be a limiting thing. Certainly, fluids and the cardiac status is itself can be limiting, because sometimes the kids get fluid overloaded very quickly. Then time, how long can you spend in there sort of doing it? But I think the best thing, and we were doing a bunch of research on the 4D flow and trying to sort of predict based on that, use that as a predictive tool to say preemptively, hey, if I close these 3 particular branches and I take this much flow, then that should do it. But it turns out probably just the ultrasound, insunating the descending aorta as you're closing pedicles may be the right way of doing it.
That's really interesting. And do you, in terms of monitoring during the embolization, are you mostly just doing angiography, or are you doing hemodynamic measurements as well? It sounds like you're doing ultrasound as well to help.
Yeah, it's angiography and the ultrasound primarily. Yeah.
And then for fetal intervention, it sounds like there's really only been a very small number of cases so far, aside from this ongoing investigational study. I would guess that you have fetal cardiology involved during the
Yes,
procedure.
right. And so right now in the United States, I think Boston is they're the ones who actually did the first case, and the trial is being run through them. and they are hoping for 20 patients. The second case was out of France, using the same protocol. And I think they've sort of calculated the power needed, that they need 20 patients to sort of show whether it is helpful or not. As of a few months ago, I think they had done a total of 3 patients, including the one in France. Um, and I think the challenge, honestly, is that these folks have to know prenatally that they have a child with Van Galen malformation, because postnatally, it's hard to transport them if they're in distress. Let's say from Chicago to Boston, or so they're hoping that if we identify folks who have this possibility of a aggressive sort of neonatal presentation, that they are willing to take those patients into this trial. And I think it's worth certainly investigating this to see if it helps. I think the alternative approach is good too. This one where if we intervene before the transition to sort of once the child is born, within that 24-hour, that massive sort of hemodynamic transition takes place. That's what really causes the injury, is this switch when you lose the placental circulation, which is low resistance, and then you sort of get the change in the pulmonary resistance. And then now your resistance is in series, and that really is when they fail. And so one other possibility, in addition to doing this in utero, is to sort of do a planned delivery and just say, as soon as the kid's born, we will do an MRI, MRA, make sure the brain looks okay, and immediately go to embolization.
Thank you. And you mentioned it in your presentation, and I think from my knowledge, the most common association with Van Galen malformation from a cardiovascular standpoint is a sinus venosus defect, a superior sinus venosus defect, and potentially associated partial anomalous pulmonary venous return. I think I've personally only seen maybe a couple cases prenatally or in the neonatal period, but I know at least a couple of those that I saw had an associated malformation, sinus venosus defect.
Yeah.
Is that something that influences postnatal care? If there's a congenital heart disease, does that change the hemodynamics, or does it change your interventional thought process?
It's a good question. I would say in general, probably doesn't change what we do up front. But I had one case where and I have to uh, admit that I don't remember all the various heart defects, but this kid had so many cardiac anomalies. I think there was a VSD, ASD, partial anomalous pulmonary venous return. There was a pulmonary outflow tract stenosis. So there were so many cardiac things going on that there was a debate between like the team. Hey, what do we treat first? Do we treat the brain part first? Do we treat the heart part first? And so I did a transarterial embolization on him, and we discussed it together with the cardiology group, and we thought, okay, now maybe it's good to treat some of the cardiac pieces. But then I had to go back, and we didn't have a good arterial approach, so this was a staged transvenous treatment, similar to what you like saw with this fetus. And so we did 3 transvenous treatments, sort of progressively occluding the vein. And that child, I think, stayed in hospital in the ICU almost 9 months, and then finally went home. So between the various cardiac interventions and then finally, so I think closing this malformation, uh, we managed to, I think, get this kid to be able to go home. But it is a good question, because we were all scratching our heads. Well, should I do my piece first, or do you do do you do this thing first? And it wasn't always clear, right? So you just have to have that discussion and say, well, the amount of shunting I see through the brain, once I did this, doesn't seem enough to explain, what's going on hemodynamically. So perhaps it's time to do something, for one of the cardiac issues. And I think that's where this it's not 100% clear, but where the discussion helps. Yeah.
Yeah, it sounds like it's very much a multidisciplinary discussion
Oh
where we
yeah,
have multiple anomalies to figure out the physiology, which is not straightforward.
absolutely. Yeah, you're absolutely right. And then, it's, I think in some instances, it's like a educated guess, basically.
Great. I'm not seeing any questions. I have one more myself. So in terms of prenatal detection of this, I would imagine obviously you would can potentially see the abnormal uh, vasculature and flow within the brain on potentially an anatomy scan. But from a cardiovascular standpoint, how many of these patients look like they have, cardiomegaly or signs of high output state from a
Yeah, I mean,
cardiovascular standpoint?
that's an excellent question. What we've been looking for is, signs of high drops and um, certainly cardiomegaly. And I think what the Boston group did very nicely with this sort of retrospective analysis, nobody had really been measuring the size of the vein. And I think this is a really elegant thing that they found out because seeing that draining vein, whether it's the straight sinus or the persistent pulsing sinus, is not so hard on fetal MR. And it's a sort of a nice, easy to do measurement to say, with a high degree of sensitivity that, oh, this measurement is going to correlate with this kid needing something done fairly soon after birth. And I think that's sort of where this alternative approach may be helpful too, because if we can identify them, I think doing the fetal intervention takes an even greater degree of, interdisciplinary work and creating a protocol. Um, but uh, I think that the elegance was just, hey, this measurement here will tell us with pretty good accuracy whether we need to do something more. So it allows us to plan, basically. So in the past, I would say, many times I would get a call and said, this kid was born, 7 days ago. We haven't been able to get him off the ventilator. And then we would, investigate and intervene. But I think with the prenatal diagnosis hopefully becoming more frequent, then I think it allows us to plan, which I think is usually good, right? And anytime you do something planned, I think the outcomes are probably better. Yeah.
Right. Well, I'm very excited to see how this investigational study turns out. It seems like it would be very likely to improve outcomes. So I hope that
Yeah, I
study.
think we'll keep our fingers crossed. I think the proof of principle itself was pretty interesting, that they could do this. Because historically, when I was, I'm an older guy now, but when I was a resident, a lot of the kids would undergo ex utero, um, through the skull with the same approach, basically into the vein and coiling, and that usually had variable outcomes. And I think it's because we didn't understand how much of the vein to close at one time. Sometimes if you close too aggressively, it was not a good outcome. And so there's this sort of sweet spot of how much do you slow the flow down. And I think that's where the hemodynamics, like the ultrasound, for example, looking at the diastolic flow, is very helpful.
Well, thank you so much again for speaking. I don't see any
Oh
questions
yeah, absolutely.
in the comments, but thank you everyone for attending. Just to remind you, today's lecture will be available tomorrow. Again, it's not on the Northwestern Cloud webpage. It'll be on a private YouTube link that we'll send out tomorrow. And do we have another slide after this? I think for the
Yeah.
next.
Hmm.
Yeah, so just to remind everybody, yeah, we don't have CME for this just due to limitations and being able to provide the series to everyone. And this is just a shout out for the upcoming fetal cardiology education series, which will be on September 19th at Lurie Children's. We have many, many speakers on cardiac and cardiovascular topics. Dr. Shaibani will be giving a more extensive talk about fetal AV malformations. So definitely a series to look into. And then do we have another slide on the upcoming talks for our series? Oh yeah, so Dr. Jin will be giving the next presentation. That'll be on September 5th. We'll be talking about complex single ventricle patients. And I know that Dr. Jin has a lot of interesting cases, so that's a good one to attend. Thank you, everybody, for attending today. And thank you again, Dr. Shaibani, for very
Thank
interesting
you. Yeah,
presentation.
thanks for to everyone for attending. I appreciate it. Thank you.
All right.